It's a good sign when there's good conversation going on. So that is not a bad thing. I just want to be respectful of everyone's time. Hi, everybody. My name is Carol Friedrich, and I am the Social Services Director in Ouray and San Miguel County. I also serve on Region 14's Regional Council as the Vice Chair. So today, this final session, we are going to be talking about reentry to the community, reentry best practices. We have a great panel for us today. So we're going to start with Lenny Woodson. Lenny holds a master's degree in community counseling and a bachelor's degree in sociology and criminology. He is a licensed professional counselor and the assistant director of clinical services of the Colorado Department of Corrections. In his role, Mr. Woodson provides administrative oversight for medical, dental, and behavioral health care within DOC. He has extensive experience treating forensic populations with a diverse range of clinical needs. He has previously managed specialized behavioral treatment programs to include sex offender specific treatment, an inpatient intensive substance use disorder treatment program, as well as an adolescent treatment center. And there's a lot more to talk about, but he's welcome, and thanks for bringing all your expertise to us. So then the next person we have in the group is Becky. Becky's on the end. So Becky graduated from University of Northern Colorado with a bachelor's degree in criminal justice and another in psychology. She went on to also complete a master's degree in clinical counseling at UNC. She started her work in jails and has had experience working with folks across the criminal justice system. She has worked in multiple jails throughout the state of Colorado as an in-house therapist, a crisis clinician, as well as a case manager. She also has experience working with criminal justice involved individuals within community behavioral health and specializes working with individuals with severe and persistent mental illness as well as personality disorders. The last 4 years, she's been working on the jail-based behavioral health services program. Thanks for joining us. Sarah Strangebye, there she is. She is the director of clinical services and contracting and works to develop evidence-based behavioral health programming and services throughout the continuum of justice-involved care. For the past decade, Sarah has worked to integrate behavioral health care in offender-based settings, working to change the landscape of community corrections in the state of Colorado. Currently, Sarah helps oversee the largest intensive residential treatment program for justice-involved clients in Colorado and has worked to integrate effective substance use disorder treatment into the many facets of the criminal justice system. And finally, we have Jessica Krueger, Dr. Krueger. She is a medications for addiction treatment, MAT, physician at the Colorado Department of Corrections. She is board certified in both family medicine and addiction medicine. She earned a medical degree from the University of Maryland and subsequently completed her residency and training in family medicine at the University of Pittsburgh Medical Center, St. Margaret. Before accepting her role at DOC, she completed a fellowship in addiction medicine through the University of Colorado and now provides oversight of the MAT treatment program at DOC, diagnosing, assessing, and treating inmates with opioid use disorder, providing education and training to correctional health care providers across the state, and helping to develop MAT-related medical programs, treatment standards, and clinical pathways. So we welcome our panel. So we've got a lot of, a round of applause. So we have a highly qualified group of folks with us today to talk about reentry, so folks that are coming out of prisons and jails and back into the community. So as you kind of think about this topic, we wanted to start by sort of just having the audience ask any question that you might have about reentry, just to kind of think about that. For folks online, if you want to put your questions in the chat, we'll make sure that we address those questions here as well. So does anybody, to start, just have any questions about reentry, any situations you've been in that you were kind of wondering about what was happening and how it works? So anything to start? And I'm actually going to have you ask that question into this mic so the online folks can hear it.
I know it has only been...
Do them both.
I know it's only been since the beginning of July, but I was just wondering, with your involvements, what is the landscape of the JBBS, the Jail-Based Behavioral Health Services, looking like?
So I can feel that. Do I do something with this?
That's apparently just for online. You need the
Oh, okay, so I need the mic too. Okay.
Way above your head.
I can scream, but I don't think anybody would appreciate that. Okay, all right, cool, that works. So I'm assuming we're talking about the 1326 mandate from Senate Bill 221326. Okay, so my role is one of the 3 program managers for JBBS. So we've really worked really hard with our jails, who have also worked extremely hard over the last year to make sure that they are compliant with 1326. So pretty broad question, so I'm going to do my best to answer your question, but we're not really seeing a huge change yet, right? We're seeing some numbers go up. We're seeing definitely more methadone within jails, which is great, which is fantastic. We are seeing that more jails that didn't have any type of MAT treatment program, specifically like in our northwest-ish area, northeast-ish area, didn't have a ton of MAT treatment. We're seeing a lot of clients there who are being placed on, so inducted within the jails, which is really awesome. We are also seeing a little bit of a snag getting methadone in frontier jails, more rural jails, right? So Gunnison has had a pretty hard time getting methadone there, but we have worked with certain OTPs. We've worked with Denver Recovery Group over here, Denise Vincioni and her group. When they do have a methadone client come up, they know who to contact, they know what to do when they have somebody come up that has those needs. So we're really, really rocking and rolling within these jails with 1326. Did that answer your question?
I asked it broad on purpose. That
Okay.
totally answers.
Okay, awesome. I tried to cover everything that I could under 1326. There might be a lot of questions about jails in 1326 too. There are a couple of jails within the state that are not JBBS. But they do have MAT programs, right? So specifically Broomfield County, they've got a fully functioning MAT program. They're also on track to hopefully come on to JBBS, hopefully later this fiscal year, if not next fiscal year. So the other 3 counties as well that are not JBBS, we're hopeful to bring on board either this year or next fiscal year, which will bring them into 1326 and fully have MAT treatment. So we'll have it everywhere within the state for all of our jails.
Can I ask what those other 3 counties are?
Yes, oh my goodness, I knew you would ask that. So we have got, let me look up so maybe I can remember. Broomfield County, Jackson County, Costilla, and I always forget one, Eagle.
Yeah.
Eagle County.
Thank you.
You're welcome. Yeah, question over there.
Two, double-fisted.
Hello. First, thank you so much for all the hard work that you've done and all the progress that we've already seen in the community across Colorado. How about some more specific jails like Douglas County, who we've had a lot of trouble with historically? Has there been any movement with counties such as that who aren't rural, who are JBBS and still battling having methadone come into their facility?
Should we keep one up here so we can pass it?
They need to talk into this.
Oh, okay, all right. So yes, Douglas County has methadone, they have Suboxone, they have all 3 FDA-approved MOUD medications. So there should be no county jail that does not have the access to, the potential to have all 3 FDA-approved MOUD medications per 1326. We have talked to all of our jails, all JBBS jails are required to, and all have the capacity. Obviously methadone for counties like Chaffee may be 2 hours away. So not really realistic for those types of counties to induct at least. Continuations, we're gonna get deliveries. But for Weld County, Douglas County, Adams, Larimer, obviously Larimer's had it for a long time. Mesa's had it for a long time. You know, our Big 10 jails, they all have them. They're all rocking and rolling with all 3 FDA-approved medications. And if you are hearing issues, talk to me, email me, because then I will be emailing my program coordinator at that jail, being like, yo, what's up? Like, you're telling me you have all 3 medications, but then you're telling this group that you don't. So, yeah, let me know. Mm-hmm.
This is interesting miking. So jail, obviously kind of a forced rehab in some sense. What kind of things do you do to prepare them to come back out so that they, don't just get right back on drugs?
So who would like to address that?
We could just pass it down.
I think that'd be good for everybody. Yeah.
Do I need to hold both?
Doesn't have to be the JBBS show.
Thank you, John.
Okay, so within the Department of Corrections, and to kind of touch back on the previous question, one thing that we're seeing as county jails are placing people or inducing people on MOUD, eventually some of those people are making their way into the Department of Corrections. We're under legislation to continue individuals that enter the department on MAT throughout the duration of their incarceration. So that has a significant impact on DOC. We've offered SUD treatment programs for 20 plus years. We are offering medication-assisted treatment along with behavioral health care. One of the things I think is one of the more innovative things that we're doing upon reentry is that for some of our more high-risk individuals, and that's high risk for overdose upon release, we're offering what we refer to as our InReach program. So InReach is essentially an intake appointment with a community treatment agency prior to the inmate releasing from the Department of Corrections. We've seen quite a bit of success with that. It seems to be really helpful to have the inmate put a face to the treatment agency and know who they're going to see before they get out on release.
We have seen pretty good outcomes from our InReach program. So I think something like 70% of patients who are connected with an InReach provider through Front Range Clinic end up following up with Front Range Clinic in the community. So pretty good treatment retention for our patient population. Also within the DOC, beyond just continuing patients on treatment, we recently started inducing patients onto Suboxone prior to release. So we will now provide up to 3 months of Suboxone treatment or Vivitrol, we were doing that before, or a single Vivitrol injection prior to release, and we will give a week's supply at release. So we are offering patients a choice between buprenorphine and Vivitrol as to which they would prefer.
As for the community corrections side, we were also impacted by 1326, and we're required to refer and continue MOUD and MAT with our populations, which is something that we actually were doing prior to that mandate. In terms of what we're doing for reentry strategies, we do have the largest intensive residential treatment program in the state of Colorado for justice-involved clients, and we can receive referrals. We're kind of a weird place. I can receive referrals from the Department of Corrections, I can receive them from JBBS, I can receive them from probation, from community corrections, and so it really, I like to think of us as a really robust offering there. We have 108 beds, so at this moment right now there's 108 people that are receiving that care, and we do have a pretty long wait list. It's about 6 weeks, which for other beds in the state isn't horrible. We also, for clients who come through community corrections, we have occupational programming. So we're doing things like Financial Peace University. They have skills training to get resume building, jobs. We also integrate substance use disorder treatment into all of our programming. And so that's something that is required as a condition of placement. So if a client comes in and they have a substance use disorder or mental health needs, they're being treated as part of their program. And that's what we're pretty much doing.
For JBBS jails, we really try to tell our jails be cognizant of what's available in the community, right? So, if there's no opioid treatment provider within the community and we're inducting folks on methadone, that doesn't really make sense, right? They're not going to be able to drive, it's going to be really difficult to drive from Gunnison every day to Montrose every day in order to get your med if you don't have a driver's license, right? It doesn't make any sense to do that. So let's talk with that client and let's get them on a medication while they're in the jail that really makes sense for them and really makes sense for their situation. If it is methadone, let's go for it. Let's get them on it. If it's Suboxone, Vivitrol, whatever it is that makes sense for them and their situation and for them going back into the community, that's really what we want to be cognizant of. Just because it's easy in the jail doesn't mean it's going to be easy for that person in the community. There may be communities where Suboxone isn't readily available when that person goes out. So let's find that medication that is easy for that person to find. JBBS can also pay for 30 days of medications upon release. That's for pretrial clients as well as JBBS clients. So if we've got somebody that, oh no, they're getting bonded out right now and they need meds, go ahead. JBBS can go ahead and pay for 30 days. If we've got a client still after 30 days, they can't afford their medication, but they're still actively participating, we may approve another 60 days of medications while they're in the community so they can continue on those medications, and JBBS can pay for it to make sure they're set up for success.
I'm going to go back there. Thank you for your questions.
Thank you. Hi, I work down in Southeast Colorado, and I work with a lot of people in active use, some who are in recovery. And this theme of housing keeps coming up. Purchasing is impossible. Rent is just astronomical, and we're super rural. So, I mean, arguably, it's a lot cheaper here than it's going to be in my region than it's going to be in a metro area. Can you speak to some of the issues you're having around housing? Because I know there's got to be an extra layer of difficulty when somebody has a criminal record and you're now trying to find a place for them to live. And that's also such a dictating factor in whether or not they're going to remain in recovery, you know, if they've been on medication-assisted treatment. So I'm not asking you to solve the problem. I'm just more curious what it might look like in your field right now.
Let's see if your lapel mics are working. You want to just take a stab and see if it gets picked up?
Okay. So if we just talk really loud, can everyone hear us? No.
I told you I could yell.
I mean, Becky and I can be loud people.
So before I respond to that question, one thing that Becky reminded me of that the Department of Corrections is doing as well, not on the treatment side or the clinical side, but we also have a benefit acquisition team that works really hard to make sure that individuals getting out on parole are connected with Medicaid, Medicare, driver's license, Social Security before they release. So to your question, you know, I wish we had the answer that we could solve housing. One thing that we've done in the Department of Corrections, we were lucky enough to receive the COSUP grant. That we're going to use some of that funding to allocate towards housing vouchers and sober living vouchers as well. Of course, there still has to be availability, but we'll at least be able to provide some funding.
You know, one of the things that we do is with every offender that comes in, we perform an evidence-based measure called the LSI. It's the level of supervision inventory. And what that does is it looks at factors in somebody's organic life that may lend itself to recidivism. And so there's no crystal ball, right? Like I don't get to encounter somebody and kind of just make a guess if they're going to reoffend or re-enter the criminal justice system. But there are some factors that are really good to consider. One of them is housing. Do they have access to safe housing? And again, don't have the answer to it, but I have appreciated our program's partnership with Sober Livings, and we are exploring creating our own. And what we have found, again, anecdotally, and then looking at other agencies that have done this and other entities, is pairing for the criminal justice involved population, pairing a supervision type model. And when I say supervision, I don't necessarily mean from a probation officer or anything like that. I mean where there's accountability within the home. And what I believe some programs that have done this have found that renters who are in the community prefer to rent to individuals in programs like this because they know that like they're going to get paid and they know that someone's going to be walking through that house once a day and that your property isn't going to get trashed, which is always a concern for anyone who has rentals, whoever they're renting to. And so I'd love to see more programming like that come about. And I know the agency that I work with, Advantage Treatment Centers, we are looking at purchasing sober living type homes in those areas encompassing that type of a model.
That's awesome. So it's hard for me to speak to one individual community because we work with so many communities, but obviously access is a huge problem across the state. What we really encourage jails to think about upon release is sober living. Where do we have a sober living that might be available? JBBS can pay for up to 90 days. We can pay for rent, we can pay for treatment, we can pay for IRT, we can pay for up to 90 days in certain programs if that client is actively participating in treatment. We also follow up with our clients at 1 month, 2 months, 6 months, right? If they're still continuing to participate in treatment and we haven't paid for anything, say they lost a job at 6 months, they're still participating in treatment. Hey, JBBS, they're still participating, but they're in the community, they lost their job, can you cover a month's worth rent? Yep, we can do that. And so those are things that JBBS can do within the community if those clients continue to actively engage with our treatment providers, actively engage with treatment, that we can continue paying for those things up to a year post-incarceration.
I would add one more thing to that. We actually have done that currently. Like, we have a case right now where we've done that with our JBBS program. We've utilized, and it actually works really well for continued engagement. We say, hey, at 30 days, we'll go ahead and pay another 30 days worth of your rent. And it's been a really good kind of contingency management platform to get people to continue to engage in care and to continue to follow up. So thank you, JBBS.
Yay. I'll take it. Okay, we have another question.
So we're talking about reentry into the community. So we're with Denver Recovery Group, and we have 9 programs across the state, and we have kind of an opposite issue at times, where a patient is in treatment, doing well, and they know they have to turn themselves in somewhere. And we're finding that, you know, a patient has to go, like they're in Montrose, and they have to turn themselves into Gunnison. But the travel restrictions to get the methadone there, so they're so afraid they don't want to turn themselves in. And we have this issue all across the state. We have patients that are like, I have to turn myself into El Paso or whatnot. Is there a way that they can stay in their local community so that they can access their medication and not be afraid that transportation could be an issue, that they're not going to continue their methadone? Because we have had that, and we have plenty of partnerships, and everyone's willing and open, but sometimes the transportation issue is that great.
Guess I can speak to that a little bit. So unfortunately, that would be a question for jails to jails, right? So if somebody is a Montrose County resident, right, and they need to turn themselves into Gunnison, that would really be a question, can we coordinate between Montrose County Jail and Gunnison County Jail? Is that possible? If they've have charges in Gunnison, and that's the reason why they need to turn themselves into Gunnison, probably not. There's probably not a way to keep them in this county. Maybe there is, I don't know. I can help connect. I can definitely help connect those two entities. Not only do we have JBBS contacts, and sometimes, you know, everybody's like, oh, JBBS is huge. You know, sometimes we're a really tiny part of specific jails, but we can at least connect you with those folks within those jails, those decision makers within those jails, to be able to figure things out. If somebody needs to turn themselves in, let's coordinate. Contact us, contact JBBS. We can coordinate med delivery. We can get the sheriff's office along and get those meds delivered prior to that client getting there, so that client knows, hey, your meds are there. You're supposed to turn yourself in on the 10th. Your meds are going to be there on the 5th. Whatever it is, you're ready to go. Meds are there. You're all set. Go and turn yourself in. Let's get you transportation. We can coordinate transportation generally with the sheriff's office as well, that we can help coordinate those services prior to that client getting there, so we can make sure that they're all set within that jail. That's the nice thing about 1326, right? These meds are mandated within these counties. We can get those meds to those counties. JBBS can pay for delivery. JBBS can pay for transportation. Those are things that JBBS can do to make sure that client doesn't get themselves in further trouble, you know? Anybody else?
Any other questions?
Are you guys preparing your patients to get connected to their recovery community when they are released? And what does that look like?
We'll go this way. Sure.
Yes, absolutely. So part of JBBS in some counties is their support groups, and they start the support groups within AANA, whatever it might be within the jail. And then those pre-sentence coordinators, if they're pre-sentence folks, or their JBBS clinicians, case managers, are letting them know what groups are available within their community once they're released. So we want to make sure whatever supports somebody needs is available. The whole goal of JBBS, right, is to not come back, right? I want to set you up for services while you're in the jail, so I don't see you in the jail again. Like, if I can work myself out of the job, that'd be great. That'd be fantastic. I would love that. So let's see what we can do. Let's schedule appointments, but let's also, hey, here's your weekly group meetings that are available within your area. Here's 5 miles from your house. Here's 2 miles from your house. Hey, here's within walking distance. Whatever you might have around, we would encourage folks to go to if that's what they need on their journey of recovery.
Absolutely. Again, one of the things that I would speak about is in our 90-day intensive residential treatment programs, there are times that we actually, in some of our sites, we have recovery service organizations come into our program, and they're doing weekly groups with the clients. And the point to that is so that they can establish those connections and those relationships post-release. Now, challenge is that I could house somebody in Sterling for and they live in Gunnison. And so that can always be challenging. However, they're working with a case manager. They're meeting with the case manager weekly. They're looking up AA, NA, Advocates for Recovery, all the different recovery groups. Sometimes we're contacting them prior. A lot of times they say, hey, I went once or twice. I know this one person. This is all being relayed in a discharge plan. In community corrections, when there's a longer base sentence, it's so encouraged, it'll be built into our case plans with that individual. We're saying, hey, we want you to go to this. So much we want you to go to this that they don't have to take there's incentive-based passes. It's not an incentive-based pass to go. And so they get to access this really as needed and as they want to go.
Just speak to myself, I will say that I track all patients with an opioid use disorder or an alcohol use disorder who are leaving the DOC within a 3 to 6 month period. Whether or not they wanted an appointment with me, they have one. And during our visit, a lot of patients are just kind of funneling in and out of the criminal justice system. And so I am seeing a lot of people who haven't interacted with a treatment program before, who don't know what it means, like even a treatment program in their community, who don't know one, who are releasing to a different community because they're trying to escape, people, places, and things that were bad for them in the past. So a lot of my discussion is not just about treatment modalities, but also, providers in the community, what it means to go to a clinic once a week or twice a week, what that looks like, if they're, what the bus route is to their clinic. Or maybe they should consider Sublocade versus Suboxone if transportation is going to be an issue. That is unfortunately the limit of what we're providing right now, but I do work very hard to find them the closest clinic to them and make sure they know how they're going to get to the clinic, what time they need to be in line. If it's a methadone clinic, they need to be in line by 6 a.m. We do a lot of referrals to programs in the community. I think that is one benefit, for me having done a fellowship here, is I do have a knowledge of providers around the Colorado system.
So one other piece to add that the department is doing, we ran a pilot program that ended at the end of the last fiscal year. We partnered with Springs Recovery Connection, Springs SRC. I don't remember what the C stands for, but bringing in peer mentors, peer recovery coaches into the department, working within our therapeutic communities, with individuals who are going to be releasing within the next 90 days, and then connecting them to resources upon release. So the plan moving forward is to expand that. The pilot was pretty successful. That will go out for RFP, hopefully in the next couple of months.
Let me check in with the online folks. Or do we have any live stream? We're okay there. I'm going to go here and then there.
This is kind of a bigger picture question. Colorado's got a pretty high recidivism rate just in general as compared to the other, I think, 50 states. What do you think are the sort of the top obstacles to getting that recidivism rate lower? And how can we in the communities that people are returning to support our folks who are re-entering and help lower that recidivism rate?
That is a broad question indeed. So, I would start by saying, I think we can look at some of the dynamic risk factors. The first two that come to mind, primarily housing, peer groups. I think if we're really working to shore some of those things up, that's going to set people up for success.
I have to say, as an addiction medicine provider, I would really like to see continuous MAT. When people go into jails and prisons and they are forced to withdraw off of methadone, they're much less likely to pursue methadone in the community. And so understanding that this isn't just about the time that we have with them or the time that they have in jail, but this is about long-term engagement with treatment programs, that real behavioral change. I can't even exercise consistently. My weight is fluctuating all the time. how hard is it to always, always, always be battling this? And that this is really, like, as many times as we can engage with patients, this is a step towards real behavioral change. So I'm a huge proponent of continuous MAT.
Outside of housing considerations and continuous MAT care, I would echo that behavior change is hard, it's long. I would challenge all of you to think about any behavior you've tried to change in your life. I was telling Dr. K earlier, I've been trying to stop chewing my fingernails for like 5 years. And it's still a challenge. And so I'm kind of a proponent in some ways of the courts issuing sentences that make sense. From my lens in community corrections, when I get someone who's going to be with me for 9 months, that's really hard for us to establish a new neural pathway that supports extended recovery and sobriety. And so keeping in mind that community-based placement, the intentionality there is not to incarcerate them, it's to transition them back into the community. And as a district attorney, I would say, how can we do that effectively in 9 months? I'm awesome, but I'm not that awesome. That's really challenging. And so looking at making sure that a sentence, if the goal is to reduce recidivism, sets your community partners up for success.
So I 100% what Sarah has said, as well as continuous MAT, and I think 1326 is going to lead to that, where we can continue folks when they get to jail, we can continue them on their MAT medication that they have been on. So ditto here. I think also being in jails for a short period of time, it's the same thing. We are in jail, folks are in jails for a very short period of time, and changing the behavior in a jail setting. Not only do we have those same peers within that jail setting, right, that encourage those same behaviors within that jail setting. So not only is behavior change hard, but then you have these other folks trying to get you to continue pursuing those same behaviors. There's also access to the providers that we have in those jails. There's a lack of providers. There's a lack of case managers. There's a lack of folks that are able and willing to go into these jails to work peers, right? It's so hard to get peers in jails that can help connect folks to outside services once they are released. If we can get more folks within those jails, get more funding to place folks within these jails, so then we can, within this short period of time, connect them to the appropriate community providers. I think that would help a lot as well.
Thank you. So obviously motivation going to be a big aspect in any lifestyle change. What do you guys do during incarceration and immediately afterwards to try to motivate? Because if they don't want to,
I'm going to pass this one to Dr. Krueger. Let me just, primarily because Dr. Krueger works at our intake facility, so she is, in a lot of ways, when somebody's coming in to DOC, even interested in MAT, maybe potentially already on MAT, maybe considering treatment, she is one of the first people that they're going to interact with.
I was hoping to pass it off as well. So I do interact. So I am at the Denver Reception and Diagnostic Center, so I do interact with, I would say, the vast majority of patients who enter the facility. So patients can submit a kite to meet with me. I can talk about what our MAT program involves. So everyone is welcome to join the MAT program in the DOC. I have a first conversation with them about treatment or what that would look like. I would like to see a little bit more motivational interviewing. Right now, it is me and a couple of other providers, but I would like to see a little bit more related to that. I will say I am tracking patients and meeting with them prior to release, but to me that feels almost like a Hail Mary, where sometimes, I'm not necessarily related to opioid use disorder, but I'm interacting with someone who maybe has a 5th DUI, who doesn't feel that alcohol is a problem for them. They are just lonely, or they were really bored, or they've got it under control. And I think that's really hard for me to hear. And I wish that we had a little bit more touch points during incarceration, where we could kind of have this conversation over and over and over again, and talk someone into it, but maybe see someone evolve through the stages of change, where maybe they're pre-contemplative, maybe they're contemplative, maybe they're preparing. I would like to see a little bit more of that, but right now we meet with them 3 to 6 months prior to release.
So in my setting, it's a little bit different, right? Motivation is something that wanes. It comes and it goes. Some days I'm really motivated to go to the gym, sometimes I'm not. If we can capture motivation when it's high, sometimes people being in orange, their motivation increases. And so if we can capitalize on that, which is why I love jail-based programming, and begin to develop, because they're usually like in action and preparation stage. They're like, I don't want to come back here, Sarah, whatever I got to do. And so we capture that and we work to continue it. And that's where it's a really nice marriage and partnership between jail-based programming and community corrections, because ideally we're building motivation and we continue it. And when we see a dip, which we do, then we can go back and utilize a lot of motivational interviewing, some strategic change planning to help them propel towards their goals.
Also ditto.
Just drop the mic.
Boom. But also individualized programming within these jails as well. You know, we really encourage jails. If a client's goal is to get their GED, let's do that. You know, they've got a 10-month sentence. Let's go ahead and do that. Hustle 2.0 is a really amazing program that works on self-motivation, that we can purchase those books and we can help, you know, encourage that client to continue that program. Really awesome program. So, you know, those fun, more interesting, self-motivating, self-guided programs that they can maybe do to not only occupy their time, but also learn while they're occupying their time, and hopefully then help to increase their motivation within those settings. On top of what Sarah said, I mean, getting away from those crowds, getting away from those folks that continue, like I said before, you know, really poking the bear and trying to encourage those past behaviors that we're trying to change is really difficult, especially in a jail setting. So what can we do to get those folks out of that? And what can we do to get them in a therapy room? What can we do to get in a group therapy room? Or if that's not their thing, what kind of book are they willing to read that we can put in front of them? Or what program can we put in front of them to hopefully, increase that motivation while they're incarcerated?
Becky just made me think of something else, which is embedded in both of our programming as heavy case management. And so I don't want to make the statement that our case managers are life coaches, because they're not. However, in a lot of capacities, they kind of fulfill a similar type role. You're having someone you're going to meet with weekly. You have a case manager who's going to follow up with you once you're released. You know you're going to have to go and see that case manager, and we do find that helps. And so we're really making plans with the client. Again, if the client's goal is a GED in 10 months, is it realistic? Can you get a GED in 10 months? What does that take? And then let's set those little micro benchmarks. And we use a lot of, within our system, it's called Be Smart, right? We have like points that we get to give people, and then they can save up their points. Some people leave with like TVs and bikes and cool things. Yep. And other people, like I totally would, every day I'm like, I'm gonna cash that in for a soda. But they get to do those things, so they are rewarded incrementally for those positive steps.
Can I add too?
Yes, let's just
Sarah reminded me too. We'll just keep passing back. I mean, there are a lot of jails that incentivize JBBS as well. So if you're participating, if you're actively participating, if you're doing a really good job within JBBS, then you are in a different pod. You're in an incentive pod. You have more commissary that you have access to, better stuff, cool stuff, tablets maybe that you have access to that the other general population that does not. And also with release specifically, I hate for it to come back to funding, but hey, we can pay for your meds. If you continue talking to me, if you continue coming to me, I can pay for your meds. If you continue coming to me, like I can maybe pay for your housing. Like these are huge things that, hey, we can pay for this. We can help you. You got to worry about food. Maybe we could even pay for that, but you've got to worry about getting yourself back to the community and getting the treatment. And we can worry about that other stuff. And so that really helps. Let's give you a cell phone so you can call me. Let's give you, a computer, a laptop, so you can actually do school. Let's do these things within the JBBS program so you can actually get things done in the community.
Thank you.
So great conversation this afternoon. Talking about behavior change and lifestyle, and we know that it's complicated. Behavior change is very complicated, but question for all of you on the panel, is it beyond your ability, or has this been done, or is it being attempted, is to look at, to reduce some of the recidivism of looking at other lifestyle modifications, such as just getting a healthy diet, sleep, the importance of sleep, physical activity for reducing stress and, boosting natural endorphins so people feel better and maybe they're not having those cravings, other issues going on. But can you talk a little bit, do you even have that capacity, or is it just, hey, you're dealing with the basics and you don't even have time for this, or do you? About other lifestyle improvements, coaching, that sort of thing on these basic healthy behaviors that would maybe support or enhance MAT recovery, keeping people out of jail, all that kind of stuff.
So I have to speak more generally because every jail is different and what every jail does is different. Do we encourage it? I want to say it also depends. It depends on where a client's at, right? If we need to focus on the basics, on food, on housing, on hygiene, that person needs a pair of boots because they came in July and they're leaving in December. We're going to focus on that, right? But if we can focus on an exercise program, if we can focus on nutrition, let's do that. There are jails that have asked if they can use JBBS funds to purchase exercise equipment specifically for inmates. Yes, they can do that. Let's go ahead and let's develop an exercise program. Pueblo County has in the past, they have the program fully developed now, at least they did. They had a CrossFit program for their folks where they actually were doing CrossFit for their inmates within the jail setting. We encourage that if that's what those clients, if that's where they're at, right? Some they need to focus on the basics, but we absolutely can purchase that equipment. Nutrition books, nutrition counseling within the jail setting, absolutely that's what we can do and encourage our jails to do. Sorry, that's very broad, but Sarah can be more specific.
I can be more specific. So embedded within our IRT programs, and every site has a nutrition course once a week. And so, and I say course, and that's not the right word, group. And so in these groups, there are a wide array of very awesome things that they're doing. And some sites, they're growing their own food, and then they take their own food and they figure out how to make meals out of it or incorporate it into their meals. Gonna be really honest, healthy food is really expensive. I get paid about $100 a day per client's head into bed. We just heard previously how expensive it is to have clinicians. I have the state telling me your dosing hours are this high. I mean, there's only so much that this goes. And so I do think that's a consideration for a lot of people to hear. In community corrections, in terms of healthy lifestyle, again, I would urge everyone to think about the limitations that exist within our incarcerative statuses. So a jail is going to be more restrictive and have different restrictions than DOC. That's going to have different restrictions than I do. I can speak for our agency that if an individual comes with a unique want or need that will support their sobriety, we're willing to staff almost anything. We'll hear it out. The answer might be no. It might be not right now, but we will always consider it. I'm trying to think of some kind of cool things that people have done. We have a lot of people who go to the gym, and that's part of what they do, and that's awesome, and it's off-site, and we want to develop that relationship for them.
Honestly, I feel like a lot of my work is building a therapeutic relationship with the patient, and I think the patient population that I'm working with has a lot of distrust of medical providers and a lot of distrust of the medical system in general. I think a lot of them are surprised to see that there is someone who knows about methadone at the prison. So I think that like building a strong therapeutic alliance, I think is really helpful in terms of encouraging healthy behaviors. I will say also being primary care trained, being able to answer questions about Hep C or what it means to have Hep C for 20 years, or being able to treat Hep C in addition to just this release plan or this intake plan, I think has been really helpful. Patients are very grateful, are surprised that they could be cured of Hep C and that we could do that within the DOC. We do have a Hep C treatment program within the DOC, so I think those things have been helpful. It's not like someone comes to me and I'm like, oh no, another primary care issue, I can't answer it. So I think that has been helpful too in building a therapeutic alliance.
So I'd say if there's any benefit to the Department of Corrections, it's that we typically have a greater amount of time to spend with the patient. Within our therapeutic community, I just visited our TC at Sterling a few weeks back, and we absolutely encourage living a healthy lifestyle outside of just treatment. That program there is running a CrossFit program. We have a former incarcerated woman, a former resident, that comes in, I believe it's once a month, and facilitates a CrossFit class. TC participants continue that on weekly. They're running CrossFit competitions, and they actually encourage staff to participate as well. So the day that I happened to walk through, we had staff members in gym clothes right next to the TC participants running a CrossFit class. That's one example, but absolutely, we do encourage living a healthy lifestyle. Outside of therapeutic community and actual treatment, another benefit within the Department of Corrections is just the educational opportunities, the job opportunities that they're able to gain while they're there. We offer college courses, lots of other training programs that can benefit them in their life as they go out on parole.
Becky's a CrossFit coach, so clearly she needs to bring that to every jail. CrossFit.
I was just going to ask about hepatitis C, so I was wondering if you could talk more about that program, what it looks like in different facilities, and Becky, if you know anything about jails doing hep C screening treatment.
I don't, JK, I'm sorry. I don't know about the jails. Yeah. Huh?
You make us screen everyone.
I'm sorry.
She makes us screen
They do
everyone.
screen, but other than that, I don't know, JK, sorry. Oh, I think.
Oh wait, we have more
can
up here.
speak.
I can answer.
Yeah, they can
Oh,
speak
can
to
you
that.
speak to that? Thank you.
Unfortunately, I cannot,
Sorry,
but.
I apologize.
We have something.
No, you're good.
So we do screen for hep C for everyone who comes through the DOC, as well as hep A and hep B antibodies, and we provide immunizations if needed. When patients come through, I think they get a CBC, a CMP, and a hep C, so we basically assess how likely they are to have fibrosis. And yes, we treat, I mean, I don't know, there's no way to say it. There's a standard protocol. If someone screens positive, we follow the protocol. They get treated.
So 100% people get treated if they have hep C?
I would say some patients don't want to be treated, but if they indicated an interest in being treated, absolutely that would be possible. Also, if patients have a relatively short sentence, maybe by the time that the lab work processes, they go to their permanent facility, their intake provider at the permanent facility initiates treatment. If they had a short stay relative to that, they would be allowed to leave with treatment.
May I borrow a piece of paper and your pen, please?
I had a question.
May I borrow that real quick?
Yeah.
JK, I just wanted to mention, I'm gonna follow up with jails, because I don't like that I don't know, so I'm gonna ask.
And one thing on our end, in our IRT programs, we have partnered with local entities, and I believe every single person who's in IRT is granted the option to begin the protocol and the testing and all the things that I don't know about, but I have really good friends that know about them, and they come in and they handle that. So again, in our community corrections agency, everyone's getting the opportunity to get screened for that.
Thank you.
So I'm just curious what you all would like to see communities have for people when they are released, like bare bones and perfect world of rainbows and unicorns. Like, what would be the most ideal for each community to have, and what would be the bare minimum for each community to have? And think maybe small, rural, because, you know, the cities have more.
These are really interesting questions. That's really got me thinking. So I'll start with bare bones. You know, thinking about rural communities first and foremost, actually having a treatment provider in the area, having medication-assisted treatment. Because it's at the forefront of my mind, you know, with one thing that we're working on, what I'd like to see is for every community and every treatment provider to have a cadre of peer recovery coaches that they can go into county jails, they can go into the Department of Corrections and help assist with that transition. I do sort of a longer term vision. I can see a future where the Department of Corrections hires peer recovery coaches that work within the Division of Parole as DOC staff members. Ideally, those would be people who have lived experience that can go in and out of prisons and help with that transition. And again, that's something that we're piloting. Right now we're using an outside agency, and that's probably what we'll do for the foreseeable future. But longer term down the road, I would like to see that institutionalized and actually hire peer recovery coaches.
Gosh, I don't know if that's something that I've ever really thought about. I guess expanding on what Lenny said, I would like to see a continuum of resources available in communities. I will say what's right for one patient isn't necessarily right for a different patient. And I think that, you know, there's this idea amongst patients and maybe amongst providers too that kind of, you know, once you're sober, you're done, or like, you know, the goal of treatment should be to never use again, right? Where what I would like to see is like a ladder, like a continuum of resources, where if you're doing really well, you're at the bottom, you're outpatient, right? If you're struggling a little bit more, maybe you go to an intensive outpatient program, maybe you go to a partial hospitalization program, maybe if you're really struggling, you go to a residential or a sober living program. And maybe if you're really, really struggling, you go to the hospital, right? Because there's no other place at this point, you're really sick. So I would like to see a breadth of options available to patients, and not just medication options available, but behavioral health options as well.
So we've talked a little bit about sober living and access to that, MOUD access, and then recovery coaches, and ditto to all of that. One thing I would kind of urge communities to think about is crafting a place, and I think it actually was a Sedman group that kind of got me thinking about this, something about like employers being able to identify themselves as recovery friendly, so that individuals who are coming out and they're in recovery, that they know that there's an ally there to receive either get a job, make it easier, or just initiate a conversation. I think one thing that we see a lot is that, and I get it, right, I'm an employer too, like I understand, but maybe a little flexibility with people who say, hey, I need to go to my meeting, which is at 9 o'clock, what that looks like.
Again, yes. I can go with yes.
Because yes, yes.
That's what's nice about being last, yes. But I think also just access to timely, appropriate treatment providers. You know, and just treatment providers in general, right? I was speaking to a county just the other day, and I'm like, what do you guys do to transition these folks to providers? Do you have a provider within the community that you can get in within a couple of days release? They don't have one. This community, there's 4 communities actually for this one provider that does not have timely provider to push these guys to. They're 6 weeks out, 8 weeks out. 10 weeks out for an appointment, for an intake, just for an appointment, and that's crazy. Like I'm emailing to try to find televideo sources for these folks in these communities so they can have some kind of provider that they can talk to, case manager that they can talk to, therapists that they can talk to when they leave. I think communities, food pantries. You know, I came from a community that it didn't matter what you were doing, what was going on that day. They had a food pantry once a week that you can just go into the neighborhood. That is a neighborhood that I had never seen before, that anybody can just walk into the neighborhood food pantry. I think that would be huge for folks, having access to food, healthy food that is free or cheap. You know, providers, having a provider that can prescribe or continue medication once you're released. They are not easily or accessible or timely. And that's really the key here, right? Timely. Getting an appointment for someone when they're released 2 months out, that's not going to help that person. Getting an appointment 1 day out, that's going to help that person. We had somebody that recently was released, and he went to the provider. The provider said, no, I don't have you on the schedule. Scheduled him 2 weeks out, and he went and used that day. Of course he went and used that day, because if he would have had an appointment that day, he would have been okay, or at least had a better chance of being okay. And so I think really timeliness is really something that we really struggle with in all of our communities.
So we have about 5 minutes left. We're winding down our day. I'd like to give the panel a chance to just talk for a couple of minutes. If there's anything else, any other best practices that that you all as professionals and experts in the field have experience that want to share with this group that just didn't come up during our question and answer. And if you don't, you can just pass it along, but just wanted to give our panel an opportunity.
I don't know if I have anything. I'm trying to think. We can send it in. All right, we'll send it back. I'm going to skip for now.
Okay.
All right.
Sounds fine.
Thank you.
Yes.
I would say rest assured that when individuals love pre-arrest, love deflection, love all of that, sometimes they do yield incarceration, sometimes it does yield sentencing, and in those cases, those individuals are not forgotten. There are treatment options. I gotta kind of brag because it's my occupation, right? But they're good, solid, quality providers. And hey, I look at it this way. I'm an opportunity dealer. My job is to craft opportunities for people, and just like with my 9-year-old son, I craft an opportunity, and sometimes he tells me to pound sand nicely, and that is his choice. There are also people that completely change their lives. And personally, I like to live in a society that will do things for the people who change their lives and can continue to live, have their families back, work, and rejoin society and live wonderful, productive lives, even if somebody tells me to pound sand a few times.
I think I'm preaching to the choir for most of the room. I will say one thing I would have liked to talk about is why we're having this panel in the first place. You know, opioid use really is a chronic disease that is relapsing and remitting for most people. And, you know, there's this idea that if you're strong enough or motivated enough, you know, you can do it. I will say up to 90% of patients with an opioid use disorder end up relapsing within 1 to 2 months without medication. So understanding how crucial medication is to recovery is something that I would really like to impart. And why we're talking about this in the first place in general, I feel like, you know, the risk of relapse in the first 2 weeks after release from prison is so great. The risk of death from an opioid overdose is 129 times greater than the average state resident in the first 2 weeks after release. So it is really important that we're initiating people on medications. Doesn't matter what one, right? The best medication is the one that the patient's going to take, that they would like to take, or that they feel works for them. So just imparting how grave this is super important.
I feel like we should have ended with that. That was really good. That was good. So, you know, the only thing that I'll add to just thinking about that crucial 2-week period, thinking from a Department of Corrections perspective, we're really trying to push InReach. You know, we have quite a few treatment providers that are unwilling to work with us because they don't know if that individual getting out on parole is ever going to actually go to them. You know, people are busting at the seams with patients, so they're not really looking to drum up business. But we really need more providers who are willing to, you know, participate in an InReach session. Outside of that, I think just in this format today, just the collaboration, I learned from this group, you know, thinking about the motivation. Dr. Krueger and I were kind of whispering to ourselves, I think we need to do more along with motivation. And it's sort of the same issue that I was just talking about, that we're also busting at the seams with individuals who need treatment. So we're not out there trying to drum up business. So we're not thinking as much as we probably should about motivating people to get involved in treatment.
I do have something.
See, I knew Becky was
And we'll pass it down.
Take me a second. That's why I like being last. I was just wanting to mention, you know, we've talked a lot about motivation. We've talked a lot about timeliness to meeting providers. I think there's also this connection. I don't know what to do because my client's leaving, and I don't know who to contact because my client's leaving, going to a new community, and I don't know anybody in that community. I work at the state, and I work with 49 of the 53 counties that have jails. You know, out of those 53 counties, I have contacts at every single one of those 53 counties. There are also people in this room, I'm looking at Amy and Robert, that have contacts at all 64 counties. I've got contacts pretty much at all 64 counties. If you don't know somebody, contact somebody that you know has these contacts. And if I don't know somebody, I'd be like, hey, I know somebody in Pueblo that maybe has a contact with somebody in Lamar, so I'm going to contact that person. Outreach them, reach them, and that's what I really want to say. Connect with the folks that you know, and use their network to help your clients. And that's ultimately what we're here for. We're here to help these clients hopefully not come back, and use your network so you can hopefully then connect them as best as possible, so hopefully they don't come back and see you anymore.
And we have one online question that we're going to wrap up with. Thank you for those that are watching the live stream.
Thank you so much. And the question is, can you please provide the email addresses to the speakers on the panel? I may broaden it and say, for folks who want to partner with you or work with you, how can they get in touch with you and your team? I will mention this is recorded, so if you do want to provide your email address, I would just recommend doing it twice or a place where they can reach you, and maybe close out on that note.
I was laughing because my name is kind of long. So it's my name, Leonard.Woodson, and I'm the third, so 3 I's at the end, at state.co.us. So that's Leonard, Leonard, .Woodson, Woodson, III, at state.co.us.
Mine's the same, Jessica.Krueger with an E, like Freddy Krueger, Krueger, at state.co.us. Again, that's Jessica.Krueger at state.co.us.
Good luck with mine. We can all blame my dad for my last name. But mine is Sarah Strangebye at atreatmentcenters.com. And so Sarah with an H, .STANGEBYE at atreatmentcenters.com. It's also, you can go to our website, and under the About Us, there is a way to find me.
Do I really have to say?
Yeah,
my
you
entire-
really. We all just did.
So my whole name is Rebecca Huckabee Rafelson. So are we ready? We sure? Okay. All right. REBECCA .HUCKABYRAPHAELSON at state.co.us. Do I really have to do it again? Okay, it's recorded. It's recorded. You can also you can Google JBBS Colorado. My email address, the email address for Joel Miller and Kelly Russell, my 2 colleagues for JBBS, they all come up. I apologize that you had to sit through that.
All right, so we just want to thank our panel for presenting to us today. And we want to thank the audience for just such a great group of questions. So thank you for the questions.
Thank you.
Okay, so we are finished for now. I think dinner is next, but Sue's going to send us off. Thank you.
And thank Carol Friedrich for moderating in a professional way. And she probably did get 10 miles of stretch there today. Yes, thank you all for your participation. Thanks for your enthusiasm and hanging in there with us.